hopefully by the time we get, it won't be raining by the time we get out of here, hopefully. So anyway, so as Marcia said, so my name is Patrick Horne. I'm a nurse practitioner at UF. I've been there going on 17 years. Next month will be 17 years. And I'm in the division of it's GI, hepatology, and nutrition, but I specifically work in hepatology, so liver. So what I want to talk to you about today is something that is very big and growing and really becoming more and more recognized, and that is fatty liver. So hope you guys enjoy it. And as Marcia said, I'll be happy to take questions. This presentation won't take probably more than 30 minutes, so we should have plenty of time at the end for questions if you have any. So we'll start with kind of just a brief intro. So what is fatty liver? So it really is exactly what it sounds like. So it's an excess amount of fat that builds up in the liver. We use a lot of different terms. You can see there's MASLD, there's MASH, there's also alcohol. But in general, for this presentation, it's really going to be, I might use them interchangeably, but really it's all fatty liver basically. And so it's a very common condition. It really affects everybody. So all ages, all ethnicities. Oh, I'm sorry. Okay. I'm a fast talker. I apologize. So I will try. No promises. Oh, sorry. So it's a condition that affects all ages, all ethnicities, genders, really everybody in society. And you'll see some statistics here in a minute on that. So as I mentioned, there are different types of fatty liver. So from a scientific standpoint, we use terms like MASLD, we use MASH, there's also alcohol. But again, in general, for this talk, it's really going to be mostly fatty liver. But you'll see some of those terms throughout the slide, so just so you know what I'm talking about. So as I kind of alluded to, this is a not only local or state problem, national problem, this is a global issue, and it's continuing to grow as a bigger issue. So when you look across the world, different areas of the world have a little bit different numbers, but in general, you're looking at globally about a 30% prevalence. So 1 in 3 people in the world have some degree of fatty liver disease. North America, if you look at that, which obviously contains us, is a little over 30%, a little bit higher, closer to 45% in Latin America, and then it varies. But it is a global issue. It does not affect one country over another or one area over the other. It really affects everybody. And this data is a 30-year period up to only 2019. So what we expect when we get data beyond 2019 and into now, 2025, is those numbers are probably going to continue to grow, unfortunately. So we'll start with kind of just what is the role of the liver. So I'm a nurse practitioner. I work in liver disease. So naturally, I think the liver is the most important organ in the body. Obviously, that's not always true, but the liver does a lot. So you can see here some of the things. So it detoxifies harmful substances from the body. It converts food into energy. It does produce proteins and clotting factors as well. And then it also regulates cholesterol and fat levels. So if you end up with liver disease and you end up with scarring, which we're going to touch on later on, these functions may not always work the way they should, and that's when you start getting into other issues. So what happens in fatty liver disease? So again, fat gets into the liver. Anything that affects the liver cells, whether it's fat, whether it's a virus, whether it's an autoimmune disease, anything that affects the liver cells can cause inflammation. And that's typically what we see when we see the liver enzymes go up, is we see that's a marker of increased inflammation in the liver. And so what we get concerned about with that inflammation, if it's ongoing, it can lead to scarring, or what we call fibrosis, the end result of that being cirrhosis. So a lot of people think of you can only get cirrhosis if you drink alcohol. Well, that's not really true. So yes, alcohol can cause cirrhosis, but fatty liver from other causes, which we're going to touch on, can. Again, viruses, autoimmune, there's a lot of different factors. So cirrhosis is really the end result of this inflammation and scar tissue building up over time. And that's when you start to get the issues with liver dysfunction and all of that. So what are risk factors for fatty liver disease? So there's a lot. So lifestyle risk factors, so obesity, poor diet. So that means, high in fats, high in sugars, high in, processed foods. Sedentary lifestyle, and we're going to come back to that in a few slides, but sedentary lifestyle is a big part of it. As a society, our lifestyle in general has shifted more towards a sedentary lifestyle, whether we're sitting at a desk in an office all day, or we're sitting around watching TV or whatever. And so we've really shifted away from a more active society over the centuries, really, to more sedentary. And unfortunately, that is a big risk factor for the rise in fatty liver disease. There's also medical conditions. So metabolic medical conditions. So type 2 diabetes, for example, high blood pressure, high cholesterol, heart disease. Those are all things that can contribute to the development of fatty liver disease. And the thing that I think is most interesting and is still we're learning more about is just a family history, not only a family history of fatty liver disease, but a family history of any of the above things. So obesity, type 2 diabetes, high blood pressure, high cholesterol, heart disease, all can actually predispose you to having fatty liver disease, even if no one in your family had ever been diagnosed. What we're finding when we go back and look, and even since I've been in practice, patients that we used to label as sort of cryptogenic, meaning we don't know what's causing their liver problems, in hindsight, if you go back and look, it's probably fatty liver. We didn't you don't do biopsies on all these people, but that's probably what it was. And unfortunately, again, the family history part plays as big of a role as your personal history of any of these medical issues. And then alcohol consumption as well plays a role. And like I said, we'll touch on that in a few slides. So how do we categorize fatty liver disease? So really, anybody who is labeled as having what we call cardiometabolic syndrome or the criteria is at risk of fatty liver disease. And so this is that criteria here. So we'll take it line by line. So you only have to have one of these five. You can have 3, you can have 4, you can have all 5, but you really only need one to meet the category of what we call cardiometabolic criteria. So the first one is an elevated body mass index or BMI. So greater than or equal to 25 or a waist circumference of greater than 94. So that would be overweight, obese. Elevated fasting glucose, so high blood sugar, over 100. Or if you're already a type 2 diabetic or you're on medicine for type 2 diabetes. So either one of those. Of elevated blood pressure, in this case, greater than 130 over 85, or again, on specific medications treating high blood pressure, obviously. And then high triglycerides as well as a low HDL. So your HDL is your what you call your good cholesterol. So a low one of those and or a high level of triglycerides, or if you're on a medicine like a statin or something like that. So you can, any one of these 5, if not all 5 or whatever variation, means that you have cardiometabolic syndrome and are at risk of fatty liver. So, and this is why it's important. So you can see here that if you have metabolic diseases, even if you just have one, as I mentioned, you're at a very high risk of developing fatty liver disease. So people with just an elevated BMI, so in this case, BMI of 30 or greater, anywhere between 50 to 90% of those people are going to probably have fatty liver disease. Cardiovascular disease, 69, almost 70% of people with cardiovascular disease are likely to have fatty liver disease. Type 2 diabetes is 50 to 70%, and then just high blood pressure by itself is almost 50%. So the way we sort of look at this is when we look at metabolic syndrome and we think about the heart and we think about the kidneys and we think about the endocrine system, et cetera, the fatty liver is sort of the liver manifestation of all of these. So just like people, you get heart disease, you get carotid artery disease, you have high blood pressure, you have diabetes. Fatty liver is sort of the liver part of that whole process. So what's the impact of fatty liver? Why do we care, right? So this is why we care. So fatty liver is now the number one cause of cirrhosis in adults. So again, and this is not, I'm not talking about from alcohol, this is from metabolic syndrome. It is the number one indication for liver transplant in people who have liver cancer, primary liver cancer, which is hepatocellular carcinoma, here listed as HCC. It's the number 2 overall cause for not only being listed for transplant, but receiving a transplant. So it's the number 1 indicator for people who have underlying liver cancer for transplant, but it's the number 2 for everybody who gets a liver transplant. And then it's the number 1 cause, again, for waitlisting and liver transplant among specific groups. So in this case, Asian, Hispanic, and then non-Hispanic white females. So huge issue, affects a huge number of patients. And this is why, again, globally, it's becoming a major problem. So fatty liver, we've talked on this a little bit, but can drive, it drives consequences including mortality, right? So 20 to up to 50% of patients with fatty liver will develop cirrhosis within 10 years. That's a pretty fast time frame. Again, it's the leading cause of transplant in women, and it's the second leading cause for all transplants in the country, no matter what. Liver cancer, I kind of touched on, hepatocellular carcinoma. There is a small number of patients who don't have cirrhosis. So typically you develop, your risk of liver cancer is when you have cirrhosis, but there is a small percentage of patients with fatty liver who do not have cirrhosis that can develop liver cancer. And their risk is about threefold higher, you can see here, compared to other liver diseases. It's something we're still learning and we're still studying to really understand what the exact numbers are, but it is something that we have to be aware of. And then cardiovascular disease. It's the leading cause of mortality in patients with fatty liver. And so I was actually just talking to Marcia before the talk and said, fatty liver can cause a lot of issues, but the leading cause of death right now in patients with fatty liver is actually cardiovascular disease. And you can see here that people with fatty liver or MASH have been shown are twice as likely to die from cardiovascular disease than general public. So there probably is some sort of accumulative or associated impact there. So what are the signs and symptoms of fatty liver? Unfortunately, there's not a whole lot. That's one of the problems. Typically, there really are no symptoms. Maybe you get some vague, sort of non-specific symptoms, fatigue, maybe stomach pain up in the right side, that kind of thing. A lot of these things like unexplained weight loss, swelling in the belly or in the legs, yellowing of the eyes or skin, so jaundice. A lot of those are late signs that we typically see with cirrhosis. So you're not really going to see that early on in fatty liver, and that's part of the issue. Is it can be insidious. It can really creep up on you. I had mentioned a while back that we sometimes see elevated liver enzymes, and we're going to talk about kind of diagnosis, but you don't always have elevated liver enzymes either, and that's the tricky part. So you may not know, but if you have some of those other medical issues, you are at risk. So how do we diagnose it? So medical history, again, this includes not only a good personal medical history, but a good, family history if you know it. It's not atypical for me to talk to patients and they say, yeah, my mom or my dad had diabetes, had kidney disease, and then lo and behold, you get down and, oh yeah, one died of cirrhosis. And a lot of times it's like, well, it's because they drank alcohol, and maybe it is, but they may have also they had diabetes, they had heart disease, they had all those kind of cardiometabolic risk factors as well. On physical exam, if I'm pushing on your belly and I might feel the liver get enlarged. Typically with fatty liver, the liver becomes enlarged because of the fat that's on it. Blood tests, as I just kind of mentioned, AST and ALT, which are the liver function tests, sometimes are elevated, but not always. So you can't really use those as an end-all be-all. Just because you have normal liver enzymes, but maybe you have a lot of other risk factors, probably still need to be screened. And then again, things like high blood sugar, high cholesterol, going back to that sort of those metabolic risk factors. I would say 9 times out of 10, by the time someone comes to see me, they've been diagnosed because they had some imaging study that showed fatty liver, or what the radiologist will typically call hepatic steatosis, fancy term for fatty liver. So what happens is either the liver enzymes are elevated, their primary care doctor sends them for an ultrasound, or they go into like the ER and urgent care for some other reason and get an ultrasound, and the radiologist says the liver looks fatty. And that's usually how people come to me. Pretty common. Same with CT or MRI, but I would say the majority of the time it's an ultrasound, and it's usually done for some other reason. We do liver biopsy sometimes. We're sort of in this transition period, I would say, in the science where we're trying to move away from that and more towards some more non-invasive type things. We're not going to go into those in today's talk, but I can certainly answer any questions you have. But the liver biopsy is still the gold standard for sort of diagnosing fatty liver disease, but we don't necessarily need it if we don't have to. Obviously, it's invasive. It has its benefits, but it also has its limitations. And so, again, we're trying to develop tools to make the diagnosis without having to put someone through a biopsy. And nobody really likes a biopsy, obviously. So what's the risk of untreated liver disease? kind of been talking about this throughout the whole talk, but the ultimate risk is the development of cirrhosis. So this inflammation that's ongoing over time leads to scar tissue and ultimately leads to cirrhosis, which is a fancy term for just excessive scarring in the liver. With cirrhosis comes other risk factors, so increased risk of liver cancer, obviously things like liver failure, and then eventually, potentially needing liver transplant. And as I mentioned earlier, cardiovascular disease is linked to there's a higher risk of cardiovascular disease in people with fatty liver disease. So now that we went through kind of the doom and gloom part of it, let's go to some of the positive things and what we can do about it. So treating and managing fatty liver. So it's kind of a 2 to 3 pronged approach, and you'll see what I'm talking about here in a minute. But the first one is really diet, right? So, I should say lifestyle changes, which includes diet. So lifestyle changes is diet, exercise. Ultimately, our goal is weight loss. So we'll dive into each of these in a little more in depth. But healthy diet, really the focus needs to be on like fresh fruits, fresh vegetables, lean proteins, whole grains. Stay away from, again, processed things, artificial stuff. The old adage that I always liked, and I think it came from like Weight Watchers, but I'm not sure. But anyway, is you shop the perimeter of the grocery store, not the aisles in the middle. Because the aisles in the middle, anything that's in a box, in a can, anything like that is really the bad stuff. You want to be in the produce and the deli and the meats and the dairy and that kind of thing. So that's kind of a good way to look at it. Not always the easiest thing to do, but I can preach. I can stand on my soapbox, but anyway. And then exercise. So we're going to touch on this as well, but the goal of exercise is really at least 30 minutes a day for about 5 days a week. So you're looking at about 150 minutes over a week. I'm going to steal a line from one of my colleagues who's out in Colorado, and her message to her patients around exercise is, let's see, I'm going to make sure I get it right here. Simply start and start simple, meaning that you don't have to go out and run a marathon from day one. The idea is to just get up, move, start somewhere, and then work your way up. And so I always like that one. And then again, the ultimate goal is weight loss. So this says 5 to 10% reduction in your body weight is what's recommended. The research really shows that 7 to 10% seems to be ideal and gives you sort of the most bang for your buck, if you will. But I'll be honest with you, the data also shows even a small weight loss of like 3 to 5% has significant benefit in reducing inflammation in the liver and actually reversing or reducing fat that's in the liver as well. So it doesn't have to be a massive weight loss, and we certainly don't want a rapid weight loss. We want a slow and steady over time. I'm talking 6 months to even a year. So diet. So we'll dive a little bit more into diet. So it's easy to say, go eat a balanced, healthy diet, right? Okay, done. Yeah, need a little more information than that. And so again, I touched on these a little bit, but limiting processed foods, limiting sugars, limiting trans fats. High fructose corn syrup is another really bad one, which is in everything, of course. You want to increase your intake of the healthy fats, so like omega-3 fatty acids. And all the national and global societies for liver now recommend, it's really the Mediterranean diet that seems to be the best diet that's out there. And you can see over to the right-hand side, this is sort of just a breakdown of, there's a lot of these online, but this is just one example of what we mean by Mediterranean diet. So it's broken down into different categories that you should consume either on a daily basis or sparingly and then in between. So for example, kind of on a daily basis, legumes, so beans, fruits, vegetables, healthy fats, herbs, spices, turmeric, ginger have some really good properties. You probably heard about that or seen that online. Those are things you want to have on a daily basis. And then, 2 to 3 times a week, you really want to mix in, again, these foods that are high in sort of your omega-3 fatty acids. So your seafoods, your fish, your shellfish, nuts, that kind of thing. And then maybe 1 or 2 times a week, maybe that's where you get your poultry or your dairy. Eggs, maybe less than that now because they cost $20 a carton or whatever they do. But you don't want those every day. You want those more 1 to 2 times a week, and you want more of the omega-3, fish, seafood more often. And then the red meats, which I like a good steak probably as much as anybody, and sweets are really more sparingly. So certainly not on a regular basis. That really needs to be reserved for more of a special occasion, special treat type thing. And then physical activity, which we're going to touch on a little bit more. So that's a big part of it. So that's kind of in a nutshell, the simplicity of the Mediterranean diet. There certainly is a little bit more to it. I am a nurse practitioner in hepatology. I am not a nutritionist. I will tell you that up front. We do have a really good nutritionist that works with us, and she could probably spend 5 hours going through this whole thing with you. But in general, this is what I try to communicate is if you kind of hit these categories and these frequencies, that's kind of the idea. So physical activity again. So we're looking at around 150 minutes per week, which sounds overwhelming, but when you break it down again, you're looking at about 30 minutes of exercise 5 days a week. And the data all shows walking is as good of an exercise as anything else. You do not have to go to the gym and, again, run a mile. You don't have to go lift a bunch of weights. Walking, getting your heart rate up for 30 minutes a day, 5 days a week, is probably the safest exercise for people, less impact on your joints, less likely of any kind of injury, and it seems to be just as effective. The idea is to get the heart rate up. And then I like this part here right below it that says minimize sedentary time. And so I think that's the most important thing is just get up and move. Don't just sit there, just don't sit somewhere all day. You got to get up and move. You got to get the blood flowing, so to speak. And so that goes back to the quote that I said about the start simple, but simply start. You just get up and do something, and then you'll be amazed the progress you'll make in a very short amount of time. Whether you start walking to the mailbox, maybe once a day. Next thing you do that for a week. Next week you're going twice a day, and before long you're walking much. You may be going further than you ever imagined. So you just got to build up that tolerance. So what about medications for fatty liver? So this is a hot topic. There's a lot of research in this area. We actually do have one drug that it's been almost a year now since it got approved, specifically for fatty liver. We have a lot of drugs that obviously target the causes or the underlying things like diabetes, high blood pressure. But it wasn't until March of last year that we actually got our first drug approved specifically targeting fatty liver. So the commercial name is Rezdiffra. It's called resmetirom. It's an oral pill once a day. There's 2 doses, as you can see, based on your starting weight. But it's the only drug currently that directly targets liver fat and that whole process and helps reduce fat in the liver, and then in turn, and hopefully also reverses some fibrosis or scarring if it's there. It's approved for a certain group of patients, sort of those that are in the moderate to advanced stage. So not really the early people and not the people who already have cirrhosis, but kind of that middle area. But it is available. It's very well tolerated. And so it's nice to finally have something. We haven't had anything direct in a long time. Again, controlling the underlying things, right? Diabetes, cholesterol, high blood pressure. Vitamin E has come in and out of favor over the years, especially since I've been in practice. There is some data that it may help with fatty liver. It does have some antioxidant properties to it, but you have to be careful when you use it. High doses in people who have cardiovascular disease can actually be dangerous. And so I don't use a lot of it myself personally. But if somebody brings it up or is on it, and if they have a heart issue, I kind of refer them back to their cardiologist and see what the cardiologist says. But there is some data that the antioxidant properties can be beneficial. And then research. There is tons of research in this area of fatty liver. I did a quick search just the other day, and there's at least 50 or more clinical trials out there in various stages, looking at various therapies and medications, pills, injections, all kinds of things that are out there. And we're fortunate at the University of Florida, we have a very robust research program, and we're doing a lot of these clinical trials in fatty liver. So Rezdiffra was the first out there, but there is certainly a lot more to come behind it, hopefully in the next couple years. So what about weight loss medications? So this is the big one, right? Probably everybody in this room has seen commercials or has read articles or whatever. So the two big ones that you hear about are semaglutide, commercially known as Ozempic or Wegovy, and then tirzepatide, which is commercially Mounjaro or Zepbound, right? Both once-a-week injections, both started as diabetes medications, great diabetes medications, and then lo and behold, they found from the clinical trials and once they were approved, they also help with weight loss. So then they both got FDA approved just for weight loss as well. They've also gotten additional approvals in things like chronic kidney disease, reduction of cardiovascular disease, sleep apnea, I think, is a more recent one for, I believe it was Wegovy. And they are both being studied in fatty liver, but they're not technically FDA approved specifically for fatty liver. So we think they're going to work. We're encouraged by it because they cause weight loss, which we know is a good treatment for fatty liver, but they haven't been specifically approved by the FDA for fatty liver. But more to come on that. So other ways of weight loss. So there's some older medications that are out there. Orlistat, phentermine, some people may have heard of. That's been around a long time. Naltrexone, and then semaglutide and tirzepatide we just talked about. There's some endoscopic procedures where they can do them actually with an endoscope down your throat. There's a gastric balloon. There's also a sleeve, and then sort of what I always call the more traditional ways of weight loss, which is things like gastric bypass, sleeve gastrectomy. So those are actual surgeries. That's a lot bigger process. Not everybody is a candidate. You have to have a certain BMI, and there's a whole thing you have to go through to even qualify for that, because those surgeries are usually permanent, and there's a lot of changes you have to make to your lifestyle afterwards. So it's not just as easy as saying I want to go in and have gastric bypass. So alcohol. So I've kind of touched on this throughout. Alcohol is a problem. It's been a growing problem really since COVID, since 2020. It does contribute to fatty liver disease either by itself or in combination. So alcohol liver disease is its own separate entity, separate from what we've been talking about with fatty liver from metabolic conditions. You can develop the same inflammation. You can develop fat in the liver strictly from alcohol, which can lead to the same issues. So fibrosis or scar tissue, and then ultimately cirrhosis. The tricky part is most of the time we see an overlap. So this is people who have metabolic things like diabetes, like high blood pressure, and also drink. We're social creatures. A lot of people socially drink, myself included. And so, but the combination of that can be a problem, just as if someone drinks a lot of alcohol. And the other challenge with alcohol is we don't know how much is too much, and it's different for every person. So everybody's metabolism is different. Everybody metabolizes alcohol different. And so the example I always use is you can take two people off the street. They drink the same amount of alcohol for the same amount of time over, maybe 20 years, let's say. One may develop fatty liver and may actually have scar tissue in the liver, and the other is perfectly fine. And we don't really understand why. Genetics plays, I'm sure, a big role in that. But it is something to be mindful of. So the guidelines go back and forth in terms of, do we just avoid alcohol altogether if you have fatty liver? Do we limit it? Depends on who you talk to. We don't really know because we don't know how much is too much. But at least according to the HHS right now, the recommended dose of alcohol for women is no more than 1 a day. So that's no more than 7 in a week. And for men, it's no more than 2 a day or 14 in a week. But it is something to be cautious of. So importance of early detection. So the one nice thing in fatty liver is if we do catch it early, it can be reversed through a lot of the interventions and a lot of the things we just talked about: diet, weight loss, exercise. So it's something that needs to be checked on a fairly regular basis. We usually recommend that patients who are at risk get screened at least yearly with their primary care. And that can be simply through labs. That can be simply through looking at the medical history again, looking for those metabolic risk factors. And then obviously if the liver enzymes are elevated or if there's an abnormal ultrasound or whatever, then probably we need to see them. But it's preventative medicine. It's being proactive, not reactive, looking for signs that could suggest the development of fatty liver, especially in people who are at high risk. And again, with that goes along with screening for obesity, for diabetes, for high blood pressure. High cholesterol, high blood pressure. So these are just a couple resources I threw at Marcia. I actually made some printouts from the NIH, their National Institute of Diabetes, Digestive, and Kidney Diseases, or NIDDK, as well as the American Liver Foundation have some really good resources on there that are reputable and trustworthy resources. They're free to access as well. But I would emphasize again, your best resource is going to be your provider. So your primary care provider, whoever you get your routine care from. They're going to be the person who's really going to help guide you on, what is your risk? What do you need to, if you are at risk or if you have fatty liver, what do you need to do to manage it? And then obviously, if they need further, they can send them my way. So just some quick conclusions. So again, fatty liver is common. It is preventable. It is manageable. If we just like with anything in life, you catch it earlier, the better your chances are of managing it. Lifestyle choices are extremely important. Diet, exercise, we touched on both of those, and those are both key. And then again, early detection is crucial to preventing long-term liver damage. We want to catch it early on before, ideally before any scarring develops, or if there is scarring where there's not a significant amount before someone ends up getting to cirrhosis. And so I'm just going to leave you with a couple quotes. One is from Hippocrates, regarded as the father of medicine. I like it because it talks to that idea of preventive medicine, not reactive medicine, being proactive, not reactive. So the greatest medicine of all is teaching people how not to need it. So it's like insurance, right? You want to have it, but you hope you never really need it, but it's there if you do. And then I don't know who had this quote, but I liked it, so I stole it. Empower yourself with knowledge and take better care of, take action for better liver health. And so this is kind of our referral information. Marcia will have some of this information as well, but I'll leave it up here if you guys want to jot it down, not only for our general liver clinics, but also our research team. And then we also have liver transplant information, referral information up here as well. So with that, I thank you, and I'll be happy to take questions if you have any.
Can you give us a little idea of the physiology of what actually these things do to the cells in the liver?
That's a whole nother discussion in itself, and I am not like the expert, but it basically causes apoptosis, and so you end up getting healthy liver cells replaced with fibrosis, with scarring, and so it starts around the portal tracts. And it grows, and then they start to connect, and that's what we call bridging fibrosis. And then eventually, your whole liver, is cirrhotic. That's kind of it in a nutshell.
All right.
There's chemotherapy treatment for non-liver cancer. Does that chemotherapy treatment affect the liver?
Can you repeat that?
Yeah, sorry. So the question was chemotherapy for some other indication, not liver. Does that affect the liver? Where we see a lot of issues with chemotherapy in the liver is in people who already have cirrhosis from some other cause. And so what can happen in that case, because the liver has disease, even though most people who have cirrhosis, their liver still functions quite normally. When you add something like a chemotherapy or something like that, that can sort of tip the liver over. It can be toxic and can sort of stress the liver to a point where it actually develops liver failure. Chemotherapy does not really directly cause liver disease per se.
Okay, I'm gonna come this.
Go with the mic.
Come this way.
Okay, I have no medical training at all, so I'm going to ask some stupid questions.
Not at all.
Is the gallbladder and the liver on the same side of the
Yes.
body?
Mm-hmm.
Okay.
The gallbladder is down underneath the liver.
Okay, because my husband had a lot of pain in his right, and nobody could ever figure out what it was. But he was a diabetic and had kidney diseases and probably had liver problems. And nobody ever realized what it was.
Possibly. Most of the time the pain in the right side is actually not from the liver. It's actually from things like the gallbladder or more digestive issues. The the liver itself doesn't actually contain nerves. So you really can't feel your liver. However, that being said, a lot of people with liver disease and fatty liver especially have right upper quadrant pain. And we don't know why. One of the leading sort of theories is surrounding the liver is a capsule. And if you have a lot of inflammation in your liver, the liver can expand and may stretch that capsule. And the pain they might feel is actually the stretching of the capsule. But it's kind of a theory. We don't really know. But there's something there because it's not just one person that complains about it. You know, it's just we don't really can't say it's this.
Well, I appreciate you answering my question.
Yeah.
I have one more quick one.
Yeah.
What is waitlisting? WAIT?
Oh, waitlisting. Sorry, that means being put on the liver transplant list. So you're on the wait list for a transplant. Sorry, I should have explained that. Yeah.
Does the fatty liver raises in the blood AFP, alpha-fetoprotein?
Not that we know of, not fatty liver per se. Now, what I will say is in other liver diseases, the one that's most commonly associated with it is hepatitis C, which is a virus. We do see patients who have a lot of active disease, a lot of inflammation. We can see artificially elevated alpha-fetoproteins, which is it's a cancer marker that we do use in liver disease. But typically with fatty liver, I'm not aware of it being strictly, specifically correlated. Outside of cirrhosis. And then,
Thank you.
Yeah.
Thank you for your presentation. Yeah. I have a question regarding the metabolic disease. And I don't agree with your answer to the third here because when you have chemotherapy, you kill good cells and bad cells. So I don't go along with that answer. Okay, that's point number one. Second, if the liver disease is metabolic, is it genetic too or not?
So it can be, yeah. So we see a strong association, obviously, with personal metabolic disease, but we also see fatty liver develop in patients who don't have any personal history of diabetes, heart disease. But when you look back at their medical history, there is a strong family history, genetic component to those. My famous, or sort of my go-to sort of story is I had a young college student, this was right after I started, who came in with elevated liver enzymes, and we did an ultrasound, and she had fatty liver. She's a marathon runner. She doesn't drink. She doesn't smoke. Her BMI she's not obese. She has zero risk factors for fatty liver other than all of her family, both sides, had cardiovascular disease, had diabetes. And at that point, we even did a biopsy, and her biopsy showed fatty liver with scarring, with fibrosis. And those are the tough ones. Those are probably not the norm, but yeah.
The last one, regarding the drug dependency of the treating the fatty liver, is going to be forever or is going to be a time limit in that?
So that's a good question, and I think that the jury is still out on that one. So these studies are ongoing. So the drug Rezdiffra that did get approved, it got approved. They treated patients for a year. They did liver biopsies at the beginning and liver biopsy at the end to compare. But it's an ongoing 5-year study, so we're going to get more data. We suspect that. I think it depends. We know people who effectively lose weight can, in some cases, actually resolve their fatty liver. It actually can completely go away. So I think it depends on. I think it just depends. But so I'd say it's possible they could be lifelong therapies, but they may not be. We just don't know yet.
Well, thank you very much.
Yeah.
Good question.
Thank you.
Sorry.
Well, I read someplace that the liver is the only organ that can regenerate itself. And so could that be the reason why somebody like that athlete was showing, that it can regenerate itself and that you can cure it? Yeah.
Exactly. So, we see this a lot with alcohol specifically, but we also see it with some other liver diseases where if you can take away what caused the insult, so whether it's alcohol or whether it's a virus or, if it's metabolic stuff, if you lose weight, if you control the underlying risk factors, the liver can regenerate. And so that is sort of the idea behind you can reverse some of the damage if there is any, and you can actually repair it. Where it's not as clear is in people who have already developed cirrhosis. Once the damage is done, it's sort of done. There are some people who maybe are in that early stage where maybe they're on their way to cirrhosis but haven't gotten there yet. They might be able to reverse some, but typically once you have cirrhosis, you're gonna have cirrhosis. But less than that, that's exactly, it's a regenerative process. So if you take away the insult, then you could potentially reverse that.
Thank you.
So the liver flush things don't work, do they?
Sorry. Oh, there you are. Sorry, I didn't. Correct. So I should have mentioned that in my talk. So these liver cleanses, these liver detoxes that are out there, none of them work. And honestly, the thing you have to be careful of with a lot of those is there's a lot of things out there that can be liver toxic. It's a small risk, but having seen people who have had that happen to them, it's quite scary. And so risk versus benefit, there's really no benefit. And so I would say the risk definitely outweighs the benefit. So that's what from a professional standpoint, we say stay away from that stuff.
I've had several people tell me to take B12. Is that something?
Not specifically towards fatty liver. B12, I mean, some people, it helps with energy and that sort of thing. What I always tell people what we usually recommend to people, the only sort of supplement we usually recommend to people to take is a good multivitamin. That being said, if you're low on B12, then it needs, or vitamin D or folic acid or whatever, then I would say get it replaced. But if you have adequate B12 and you take B12, your body's only going to absorb what it needs and then you're going to excrete the rest of it. So it's not really directly beneficial to liver now. It's not harmful, but.
I was diagnosed with fatty liver about 5 years ago, and it was just through an abdominal CAT scan. I also had a fibro scan done about a year and a half ago, and that did not indicate fibrosis. But my doctor started me on 2 medications, and I just wanted to ask what you think of them. One was Actos, and the other one is Actigol.
Yeah, so Actos, which is pioglitazone, is an older diabetes medication. There is some and I apologize, I should have put that in there. There is some good data that it can help with fatty liver. Dr. Ken Kuzi, who's one of our endocrinologists at UF, he's done a lot of research in that area, and he's a strong believer in it, especially in early stage fibrosis. So yeah, there is some benefit. There's been some data showing benefit. It's not one that I routinely prescribe because I'm not in the endocrinology world, but especially people who are diabetic, who are already on it, I certainly would say stay on it. The Actigol, that's also known as ursodiol. We use that, there's not really an indication for that in fatty liver. We use it in some other like autoimmune genetic liver diseases. It works within the flow of the bile. There's not a lot of good data that I'm aware of that it really is. It's a pretty benign medication. It's not really going to hurt. I'm not aware of any data that it really would help much with fatty liver.
So your first choice then would be however you pronounce that, the ref.
Well, not necessarily. So in the situation that you described, where there's fatty liver but there's no fibrosis, that's actually not the role for resmetirom or Resdifra. That it's for people who have a fair amount of scar tissue that have built up. In your case, it's really the best treatment is still weight loss or diet, exercise. The goal is weight loss. Actos or pioglitazone, is fine as well. Especially again, I reserve that more for people who are diabetic. I would not probably recommend putting a non-diabetic on that drug, and I don't think Dr. Kuzi does either. I think he only uses it in his diabetic patients. But there is some good data in diabetic patients that it could be beneficial.
Okay, because I'm not there yet.
Okay, yeah.
Okay, thanks.
I have two questions. There's something over the counter that you can get, ALLI, that if you take it, it excretes fat, but I don't know where that's coming from. Could you explain?
So I will tell you, I don't know much about it. I've heard of it. It's kind of like, it's the, I want to say it's like the modern version of like the fin and stuff. I think it just pulls like the fat out, and so you get the really nasty, greasy stools. I think it helps with weight loss. I really just don't know much about it. It's not something that we recommend.
Okay, the second question is, I have been diagnosed with fatty liver, so what makes the blood counts go up and down?
You're talking about the liver enzymes?
Yeah.
Yeah, so that's a good question. So it's very common that they fluctuate in fatty liver. And as I mentioned, they can be normal, they can be elevated. It probably has to do with inflammation and how much inflammation is going on in the liver. Unfortunately, without a liver biopsy, there's no way to really gauge the degree of inflammation going on in the liver. But typically when we see elevated liver enzymes, it would signify that there's some degree of inflammation. But I didn't bring this up in the talk, but inflammation in fatty liver specifically is not what we would call linear. So it doesn't progress on every year it gets worse and worse. It waxes and it wanes. And so one of the limitations even with liver biopsy is it really comes down to the timing of the biopsy. So I could biopsy a person one time and they may have a lot of inflammation going on. And then I may biopsy them a year later. Nothing else has changed. They haven't lost weight. They haven't done anything different, and they may have less inflammation. So it's not a linear disease. And that's one of the hard parts of understanding it and treating it, is because it doesn't progress like other liver diseases progress it's almost like clockwork. We can sort of predict without doing something how people are gonna progress, but fatty liver is not that way. So, but it's probably just when they're elevated, it's probably there's more inflammation in there, and when they're not elevated, there's probably not as much inflammation. That's what I would probably say.
So does inflammation cause scarring?
Yes. So over time, and so that's the thing. It's going back to the question about regenerating. It's inflammation that leads to scarring. Then the liver may regenerate a little bit, and some of that scarring may go away. And it's this back and forth, but it's when there's more scar than the liver can get rid of over time that is what leads to cirrhosis. So it's this back and forth, but eventually you can develop too much scar that the liver can't regenerate enough.
I have a question regarding the liver function. You emphasize that the liver function is to detoxify. So do you consider now fats as a toxic substance to the liver, in which the liver can detoxify it, supposedly? That is my understanding now with your lectures. Now, with being said that, it means that if the capacity of the liver to detoxify become limited somehow or another by time, the toxic deposition to the liver will become more serious, producing more inflammation, and therefore, of course, will damage the liver. My question now is there any intrinsic factor in the liver that delay the detoxification function of the liver?
I don't think I understood your question, sorry.
Is there any intrinsic factor, which I do not know, in the liver function, in the liver cells, that will delay any function to detoxify any toxic cells?
Oh, is there an intrinsic factor? I think there's a lot, and that's a lot of what's being studied, and that's part of that's what a lot of these drugs are looking at targeting are what are these processes. So Resdifra, for example, is a thyroid hormone receptor beta, and I won't go into all the details of that, but that's actually a thyroid hormone receptor that's in the liver. It's not in the thyroid, but it's actually that part of that process. It's actually responsible for apoptosis of fat in the liver. And so that's how so there's multiple, and I don't think we know them all, but that's an example of one that they have identified that actually has shown benefit. So I don't know if that answers the question, but.
Thank you for your presentation. Yeah. You're so knowledgeable. It comes across to us. My question is, though, what is the name of the dietitian who you said is knowledgeable in liver?
So her name is Ashley, and I apologize. She's fairly new to us, and I'm blanking on her last name, but I can get that information to Marcia. But she is fantastic. She works for our GI division, so she sees GI patients as well as liver patients. So she sees fatty liver patients, but she also sees patients with other, GI disorders.
Which department would I call so that they know who I'm talking? You said Ashley or Ashlyn?
Ashley. Sorry, Ashley. Yeah. So just the gastro department, that number, the 273-9400 number.
Perfect.
Yep.
Thank you.
Yeah, I'm pretty sure you need a referral, though, from a physician.
Yeah, so
I just being able to call.
Yeah, so that actually brings up a good point. So I didn't put that on here, but our department is by referral. So, but that can be from a primary care, that can be from anybody, but it does need to be a referral from a provider. So.
Thank you.
What values of ALT and ASD would you consider be a concern?
What level?
Yeah. In the hundreds,
so it depends. I would say any level being abnormal warrants at least a little bit further investigation as to why are they abnormal. Typically, for example, in fatty liver, it's not uncommon to see them, elevated in the 40s, 50s, 60s, maybe 70s. That's not, with a diagnosis of fatty liver, that's not a really concern for us. But if it's someone who has never been diagnosed with a liver issue and you detect elevated liver enzymes, I think it warrants at least a discussion of, have you been drinking alcohol? Have you ever been screened for like viral hepatitis? Those sorts of things. We typically, drug toxicity, which can happen, is rare, but we do see that. Typically, we're talking liver enzymes in the hundreds, if not thousands. That's a whole different ballgame. But yeah, I would say in someone with fatty liver, sort of that elevation under 100 doesn't make us too anxious. But in someone who's never been diagnosed with a liver problem, any elevation needs to be investigated.
Could you talk about a fiber scan for diagnosing liver fibrosis?
Yeah, so I didn't put that in here, but the FibroScan, it's something that we do offer. I believe the group over at North Florida has one as well. What it is, it's a special type of ultrasound. It was developed to largely try to replace liver biopsy. It actually was developed early on for viral hepatitis and then has sort of been moved over. But it is nice because it is non-invasive. It's relatively quick. But what it is, it's an ultrasound, and there's a probe that the person holds, and they put it up between your ribs, and it sort of does it's like a little light thumping. It's a pulse. And what it's doing is it's measuring it's called a shear wave. It's measuring the time that the ultrasound pulse goes from the skin to the surface of the liver and back. And it calculates out what we call liver stiffness, which correlates to potential for scarring or fibrosis. So we use it a lot because we have one. And it's a great machine because it avoids us having to probably do liver biopsies on people that don't really need liver biopsies. So yeah, it's readily available. It is available as a referral without having to see one of us. So like primary care doctors can just refer for specifically just a FibroScan. We do them Monday through Friday all day. Normally it's less than 5 minutes in and out. A little bit of gel and that's it. So yeah, it's a good tool.
He had a question.
Are there any benefits or drawbacks to vitamin E and turmeric?
So turmeric seems to, again, I think I'm not an expert on turmeric, but from what it appears that there's a lot of good antioxidant properties in turmeric. There's certainly nothing harmful to the liver with turmeric that we're aware of. There's a lot of press about it being good for a lot of things. So I think that's fine. The jury I think is still out on whether it directly has any impact on fatty liver. And then vitamin E, as I mentioned, there is some data that because it's an antioxidant as well, it may help with fatty liver, but I caution the use in people with other medical conditions, especially heart disease, because there is some data that high doses in people with heart disease can actually cause serious problems. So if it's not something I routinely recommend, because I don't know if it's that beneficial, and especially in someone with heart disease, I would defer to the cardiologist on whether they think it's safe.
Okay, you just touched on what I was just gonna ask. A friend of mine was told by her doctor to take vitamin E. She said, well, one's good, let's take 3. And her hair fell out. Some vitamins, as you use them, they're water soluble, and if your body doesn't need them, you just urinate them out. And some vitamins accumulate in your system.
Mm-hmm.
And vitamin E is one you need to be careful of. If I'm correct, I'm not, like I say, I'm a layman, but am I correct on that? Vitamin E does stay in your body?
Yes, yeah, and so when I first started, that was I was maybe a couple years after I started is when the literature kind of came out on vitamin E and fatty liver, and we're like, oh, this is great, and so we were telling everybody to take vitamin E. Well, then we started to see that there's cardiovascular risk associated with it, and there's some other things, and so we've really backed off on that. And so, again, there is some antioxidant properties with it, and I think in the right setting, it may have some benefit, but I think you have to use it cautiously, and I think the jury is still out exactly what is the right dose. Nobody knows. And in a lot of cases, again, you're talking about, almost 70% of people with cardiovascular disease have fatty liver disease, so obviously same thing. So that's a lot of people that probably need to be cautious about whether they should be on vitamin E at all. So I would say that's a discussion to have with at least your cardiologist.
All right. Thank you, everyone. Thank you so much for speaking
Thank you,
with
guys.
us today. I really appreciate it. Thank you.